Hi, everybody. My name is Alex McLeod, and I am joined by my colleagues Brian Scarpelli and Morgan Reed of the Connected Health Initiative. And we are also joined today by Commissioner Carr of the Federal Communications Commission, also known as the FCC, much easier to say. We're going to have a brief conversation with him today about just kind of the goings on at the FCC in terms of telehealth, and specifically on the telehealth COVID program, in addition to the commissioner's work on the Connected Care pilot, which we've all been very actively engaged on and looking forward to when that order came out. So it's good to see that making progress. So basically, we've taken all your questions beforehand. So we have kind of compiled them, and Commissioner Carr has graciously offered to answer as many of those as possible. So we'll make sure that we get through as many as we can. So I'll kick it off to Morgan and Commissioner Carr to take it away.
Well, thank you, Alex, and thank you for your amazing work pulling this all together. I'm checking our participants list. Wow, we're already up there in a lot of digits. So hopefully we will have a great dialogue. For everyone there, the vast majority of you are members of the Connected Health Initiative, so you know what I'm all about. But as a reminder for the press, we are an organization made up of everyone, including the tech industry, the providers in the pharmaceutical industry, the patient advocates, and the specialty medicine practices, as well as the academic medical centers, all coming together in one place to try to ensure better patient outcomes through the use of technology. What's ironic is the Connected Health Initiative was a sleepy little org that turned out reams of paper and filings on CMS and FCC and HHS, and there'd be a few lawyers who'd read them. And then COVID came along. And what we've been preaching, all of us, for years about the importance of patient outreach, of patient engagement, being able to find people at home and help provide them the care they need, became real for people. It became something that they knew. And it's something that had an impact on whether or not they got to see the doctor that they needed to see in a timely fashion. And more importantly, it became a crucial part of physicians engaging and outreaching with their patient. But as we all know, the most important aspect is no matter how great the doctor is, no matter how great the technology is, if you can't connect the physician and the care team to the patient, all this digital medicine means nothing. And so the role of the FCC as a key component is hard to overstate. Without what Commissioner Carr does, there is no digital medicine because there is no connectivity. And I think that part can't really be overstated. What's been fascinating is more than a year ago, Commissioner Carr and I sat down for a fireside chat with, I think, 50 or so of you to talk about the rollout of the initial pilot project on the Connected Care. Well, since that happened, we've obviously gone from a $100 million project to an additional $200 million around COVID. And I thought it would be great for us to kind of come together, learn from Commissioner Carr about what the outcomes are that they're looking for, what we all can do on the industry and the patient side to make sure that they're getting the results that they need to see. And then finally, what information does Commissioner Carr need so that we can drive forward for better patient outcomes? And so I'd love to hear from you, Commissioner Carr, kind of as a starting point on the overview of those two programs, where they sit, and why you've been such a passionate advocate for better patient outcomes through digital medicine.
Yeah, thanks so much, Morgan, and the whole team at the App Association for putting this together. Should be a great event. Look forward to the conversation, and thank you for your leadership and work on these important issues over the years. As you pointed out, I started down this path of expanding the FCC's work in telehealth a couple years ago. When I joined the commission, as everyone knows, the FCC for decades had been supporting through subsidy programs the build out of internet infrastructure to brick and mortar healthcare facilities. And what I saw as I traveled outside of DC trying to learn more about what we can do to help on the healthcare side, it became apparent there's this new trend in telehealth. And I've been describing it recently as this shift that's equivalent to moving from Blockbuster to Netflix, that no longer do you always have to go to a physical brick and mortar facility to receive high quality care. We now are at the point with the networks, with the connected devices, that you can receive high quality care wherever you are. And that was sort of the mustard seed behind this idea of the Connected Care pilot program. And I've talked a lot at this point about this woman that I met in the Mississippi Delta, small town called Ruleville, Miss Annie. This was the very first time that I was introduced to this concept. There was a pilot program there that was being run in conjunction with the University of Mississippi Medical Center. This woman, Miss Annie, woke up one morning with blurred vision. First time she realized she had diabetes. She wasn't seeing a lot of progress with traditional care methods. And so the North Sunflower Medical Center, the local facility, sent her home with a iPad and a Bluetooth-enabled blood glucose monitor. And she's a relatively older woman, and she walked me through very simply how she pricks her finger in the morning, and it registers an A1C level. It sends that number to her iPad, and she gets instant feedback right then about what to do that day. And she saw a dramatic improvement. A1C levels went down, and she felt a lot better. And we saw from that initial study in Mississippi that not only is it improving patient outcomes, but it's actually driving down the cost of healthcare as well. And that makes a lot of sense, because if you think about it, the most expensive part of the healthcare system are patients that end up in the emergency department. So if we can maintain treatments so that people don't fall into the range where they need to go to the emergency department, it's better for the patient, and it's better in terms of cost savings on the healthcare system. So we've been working on that for about 2 years now. We launched that notice of inquiry. We then launched a notice of proposed rulemaking. Now, obviously, when COVID hit, we'd naturally been doing a lot of work already, and we slightly accelerated that work to get 2 programs stood up. And we had this document going, and we were working on this document. And then when Congress allocated funding to us, we were able to include that as well in the same document to get a total of $300 million allocated within a matter of days to stand this up. So we're really excited about it. I do think it's the future of telehealth. We've worked closely with CMS, HHS, the work they've done as well over the last few weeks in terms of cutting red tape to enable more telehealth. We've been working really, really well with them. I think this is one lesson learned from the pandemic that we should stick with. We shouldn't pull back on the regulatory relief we've done that have enabled this, what we're seeing, really expanded use of telehealth.
Well, I want to come back to your coordination with other agencies, because I think that's important, and I know we've had some questions about that. But talk a little bit about, how do you see the Rural Healthcare Fund evolving to support this kind of connected deployment? And do you see that as being supported by the COVID-19 program in your pilot?
So this is a sort of a parallel program, parallel track. So I don't see this impacting rural healthcare. We're standing it up as its own standalone program. So you've got obviously the emergency COVID-19 $200 million, and then you've got the longer term $100 million program, but they'll run in parallel to the existing RHC programs that are out there. And of course, there's some differences between the 200 and 100 programs. So for instance, the 200 million program can cover end user devices.
Exactly.
Because it's appropriated money from Congress, whereas the 100 million is USF funds, which there's more limits in terms of how we can use that money.
Well, I think I want to dig in a little bit on that. That's really critical, because, as I said, you guys have been good at putting money into the ground to basically drag a wire from one place to another. But if you don't have the patient at the one end with connectivity, or the hospital or the caregiver with connectivity, sometimes you need to cover the device and the software that makes it all happen. I know that was something you were both passionate about and moved forward. How do you see that rolling out in the COVID project? And I know it's not in the original, but what are the areas in which we can kind of work within the original 100 million project for either coverage of software or other modalities or elements of it that you think would be helpful? And then dovetailing into it, this longer question for you is, what do you need to hear from us to let you know that you're on the right track?
Yeah. So in the 200 million program, as you noted, we have a lot more statutory authority and leeway to cover, more than just the connection between the brick and mortar hospital or the place where care is being delivered ultimately and the end user. But that said, even in the $100 million program, we looked pretty hard to see where within our statutory authority we could do anything beyond just the connection. If you read through the decision, we identified 3 or 4 different types of costs that could be included even within that 200 million, because we're very cognizant of making this attractive to providers to participate in. right now, what we are excited about is all the applications that are coming in for the 200 million. We want to continue to spread the word about the availability, so we keep getting applications in. I think there was another release today, maybe the third or fourth that we've done in terms of approving another batch of applications. And in long term, obviously, we want to hear more about how the program's working. What are the cost savings that you're seeing? What are the improvements in care that you're seeing? Because my long-term vision is that this is where healthcare system needs to go, and that the healthcare system needs to more directly absorb the cost of this sort of connected care regime. It's not entirely clear to me that this should always be something that's funded out of the Universal Service Program on the $1 million side, for instance. So I think part of this is just another set of pilots to show to the entire healthcare system, we got to reorient around this. However we do that from a funding, licensing, reimbursement regime, I think ultimately that should be absorbed by the healthcare system.
Yeah, and I think that's a really good example. I mean, it's funny. To most of the rest of us, 200 million and 100 million sounds like a lot of money, but in the 3-point-something trillion dollars that we spend on healthcare, it's really not much of anything. One of the examples that we've talked about in the past is the idea of like teleretinal, the ability of doing teleretinal services via this kind of project and having it funded, because that has some elements of all of what we're talking about, but it puts technology in the hand of a primary care physician and lets them have input from a specialist that they don't necessarily have in their small town. And are those the kinds of projects that you're thinking about that you want to see, where it's empowering a physician, empowering the patient, getting the results faster, and then the kicker, data back to everyone else to know what's working and not?
Yeah, there's so many good examples along those lines that you're talking about that just spring to mind when I think about the time that I've spent with healthcare providers outside of DC. I've been up in Alaska, for instance, and I've been at healthcare facilities, nearly halfway out the Aleutian chain. I've been at a healthcare facility in Manakota, Alaska, and there they showed me, for instance, a tool that you can put basically on an iPhone that can be used to look inside someone's ear. And this was a particular native Alaskan community that had a lot of issues associated with eardrums. And so you can look in someone's ear, and that image will be transferred either back to the facility or from that facility to specialists located in Anchorage. So you can drop in remotely, to your point, specialists that population-wise, you wouldn't be able to support that type of a specialist in that remote community, but now remotely you can do it. And they showed me how the technology worked. They put the attachment on, they looked in my ear, they put it up on the screen. It felt a little bit invasive because I hadn't cleaned my ears that much that morning.
No Q-tips, no Q-tips.
Yeah, exactly. It was good to see how the technology works. I was in West Virginia with Senator Capito, and we went with again, sort of a diabetes treatment facility where, they were looking at issues that people had with their eyes. And so again, remotely you can address and treat those things in some cases completely remotely. So you talk about this doctor divide we have in this country where rural hospitals are closing by the dozen. It's hard to get a general practitioner, let alone a specialist. Technology is how we can bridge that divide. I was in a small town, Beatty, Nevada, population of about 1,002 when I was there. The one hospital clinic in that community for, a couple hours drive from there really was going to shut down because it didn't make economic sense anymore to serve that one small town. But they kept it open because they got a high-speed fiber connection to that facility. And so they kept a nurse there, Teresa. She would check you in, and then you would immediately get set up with a secure video connection to a doctor located in what's a big town there, Pahrump. And they were able to keep that facility open and hear stories about essentially lives that were saved by people that, again, I think a lot of people are like me, like they're sort of resistant to go to the doctor. I don't like going to the doctor. There's barriers and challenges, whether it's access to transportation, hours of drive, they're not going to do it. But if you have it delivered directly to you, there's going to be greater adherence. I saw the same thing in rural Appalachia. I was in Laurel Fork, Virginia, spoke to a woman who said she had really high A1C levels, and she just stopped going because it was too much of a pain to drive to a facility a couple hours. She got into a remote patient monitoring program, and her numbers were just through the roof, like the type of numbers that people usually die from, because she just stopped going. And she now has it under control thanks to being in this remote patient monitoring program where she doesn't have to travel anymore. So we need to replicate that stuff more broadly.
And I think you're onto something. Well, first of all, I need to say that I'm disappointed you did not stop at my parents' house in Alaska, but
right.
I am proud that you got out of Anchorage and got to see all of real Alaska. Those of us who are from there. We always call it Los Anchorage, the big city, but it's really true. Basically, it's the hub of which all of our rural healthcare operates, that and Fairbanks. One of the things you just talked about, though, is remote patient monitoring, right? And that's different than telemedicine, which is a live voice and video, with which physicians are using amazingly well during COVID. But you're pointing out something really critical, which is longitudinal data about a patient over throughout their experience. We know in the diabetes context, if I take the average of your levels, I might see that you look good. But in fact, what they're really doing is up, down, up, down, up, down, which is the very kind of numbers that lead to blindness. And so the ability to do remote patient monitoring, where you're gathering little bits of data over time to paint a better picture, gives the physician the information they need to adjust medication, nudge them. And I hate to say it, Commissioner Carr, as a fellow middle-aged guy, we are terrible. We don't take our medication. We don't finish total courses of action. We're less likely to engage on and do our physical therapy. So as a group, we are the scofflaws. Our wives are great, but the men not so good. And I think that's a great thing to point out. You've been focusing a little bit on rural, and I think that's worthwhile. And I need to get this in there because I think it's critical. We're talking about these 2 pilot programs, but you've also done some really important work right now on unlocking some spectrum bands to open up things like unlicensed spectrum, sometimes called TV white spaces, in 6 gigahertz and 5.9 gigahertz rules. So when the FCC changes spectrum bands like this, how long does it take to get that kind of tech out into the field to make it available for all those rural populations that you just highlighted?
It depends, obviously, based on the spectrum band and what's there. But what's so interesting about the 6 gigahertz band, and one of the many reasons why I was so excited about it, is that we can put it to use immediately. There's talk about putting 6 gigahertz spectrum in consumer products this Christmas. And so I think that is a really remarkable quick turn that you can unlock that spectrum. And what is so interesting about 5G more broadly, among other things, is supporting IoT devices. So right now there's a limit on the number of devices that a 4G network can support in a given area. Pretty high number, but it's a limit. 5G is orders of magnitude more than that. So that can really help enable the attachment of a high number of IoT devices. And you talked about remote patient monitoring. I think you nailed it. When we talk about connected care and telehealth, it's not just replicating what you can get by going to the doctor. Sometimes it is that, but it is so much more than that. And we see this with chronic diseases. Chronic diseases are something like 85% of the direct healthcare spending in this country.
That's correct.
And adherence is what I believe is the medical term for what you were talking about people not following up and taking medication and monitoring their condition. And adherence in this country for chronic diseases, I don't have the numbers, but from my own personal experience and everything is low. And that's where remote patient monitoring, consistently providing data every day, every morning, every night, a trickle of this data back, being able to monitor that over time gives you, again, not a replication of what you get when you go into a physical facility once a month or once a week. It is a totally different type of quality of care. So that's why this umbrella of connected care, remote patient monitoring is a piece of it. These video visits are a piece of it. And that's why there's so many ranges of health conditions you can treat, including mental health. I was in an Indian reservation in New Mexico, and they were able to use video visits to, speak with specialists located in Albuquerque to get treatment. Similarly, I was in a Pine Ridge Indian reservation, which runs along the border of Nebraska and South Dakota, and talked remotely myself to see how the technology worked with a mental health specialist located, in Valentine, Nebraska, that brings that service remotely over video connection right into the facility. And think about as well about disrupting stigmas. Mental health is a challenge in this country that we need to address. We've seen some strong leadership on that front. Senator Cory Gardner, for instance, has a lot of really interesting bills and thinking about how to address that. But there's still some stigma that we just have to get over. But if you can go to a regular healthcare facility and go into a room and have a video visit with a healthcare specialist, mental health specialist, no one knows exactly, that you're seeing that type of care. And maybe that can help break down barriers to more people to get the help that people need.
I'm waiting for my 5-year-old to come knocking as well. But I don't want to belabor rural too much, but it does raise an interesting question. How do you see like emerging connectivity technologies like Loon and Starlink playing a role in last mile connectivity over the next 3 years? And if they're successful, do you think they have a role to play as well? So we talked about TV white spaces. What are the other kinds of things that you think will help bring this connected healthcare and telehealth in rural America?
I'm pretty excited about sort of this next generation of technology. And to me, I speak a lot about 5G because it's a term that has resonated with the American people. So you can say 5G and people feel anchored to what you're talking about. But oftentimes I use it in a non-technical umbrella sense to talk about next gen connectivity. So I think about all this new fixed wireless stuff that WISPA and their members are doing. I think about, to your point, Loon. And Loon is particularly interesting to me. I've actually been in Baltic, South Dakota, which is a small farming town. There's a big warehouse there actually where they build and manufacture the fabric for the Loon balloons. And I've also been on the ground in Nairobi, Kenya, where one of those Loon balloons was doing pre-commercial work and seeing it on the ground there in Kenya. So seeing both ends of that. And also we have this next generation, to your point, of satellites that are going up. I think I'm very optimistic about where we are going in this country in terms of options for connectivity and using each one where it makes sense in a particular geography or use case scenario. I'm not ready to throw all my eggs in one basket in terms of a technology, whether it's Loon, whether it's low Earth orbit satellites, fixed wireless, but I'm very heartened to see all of these moving from the theoretical into the practical, and that it's only going to increase competition.
Well, I think that's I agree with you. Obviously, as a technologist, I've always felt that 5G is one of those, makes me kind of squirm because it's not really a standard term. It's a collection of standards. I think you're 100% right on fixed wireless. I think that's going to be more revolutionary than anyone realizes. Just the idea of wireless backhaul, millwave, all of the elements that make up 5G are critical. And I know we've talked a lot about rural, but you also have enormous underserved communities that are in urban areas where, sure, by the technical language of the law, they don't meet a healthcare professional shortage area under the census determination, but yet the people who live their lives in those areas don't have it. And so I think you're completely right that 5G is not just important for North Dakota or my family in Alaska or Wyoming, but also for urban areas as well, where 5G deployment becomes really critical because, sure, there's technically a doctor 20 miles away, but finding transportation, especially who knows when public transportation is going to come back in America, getting there becomes its own battle. You can live 20 miles away from a doctor or 15 miles away from a doctor, but have a 4-hour round trip to get there if you're using the bus lines. So I think you're completely right about that, which actually is an interesting question. Noting the existing waiver for gift rules applicable to RHC and E-rate programs, what do you see as like long-term sustainable regulatory approaches for continued support for schools and libraries and the rest under a post-COVID world?
Yeah, a lot there. I think you're right. We are very focused. Our top priority is closing the digital divide. And of course, we talk a lot about build out of internet infrastructure in rural communities because it's a huge number in terms of the investment that it takes to do that. But that shouldn't be read as a value judgment about where we need to be closing digital divide. We have to close it everywhere. And the digital divide is two components. It is access to these services and the affordability of these services. And we're working on both of those fronts. And that's why I was pleased as we moved into this pandemic, my team worked directly with a number of broadband providers, Verizon, Windstream in particular, that launched from scratch within just a matter of days, completely new low-income programs to make sure that families, particularly ones with K through 12 students right now, are able to stay connected. That's a big deal. A number of other providers, AT&T, Charter, a lot of others, expanded their existing, Comcast as well, Internet Essentials in Comcast's case, other low-income programs, other providers' cases. So that was really heartening to see. To your point, we waived some rules to enable providers to give away connected devices, whether it was to E-rate or a telehealth program. We should take a look at that. Obviously, anything we're doing right now shouldn't just go back to the status quo ante when we're out of this. We need a hard look. Did it work? Was there a risk that makes it not sustainable on a long-term basis, but it totally made sense on a short-term basis? we got to look hard at that. And I would, spend time, I talk a lot about these road trips, but equally in big cities. I've talked before about spending time at a high school in the Sharswood neighborhood of Philadelphia, a historically under-resourced community. And I spoke with a young woman, a mom named Tommy, who had dropped out of school, grew up in public housing, and she explained to me in ways that I could never relate the power of an internet connection in her life. And she described it as literally the thing that enabled her to pull her family up into the middle class, whether she was doing work from home, whether she was getting an online education, staying in touch with her kids when they had to go live with other relatives, and the meaning to her life was really impactful. I've been in Houston's Second Ward, again, a community that hasn't always enjoyed the privileges and benefits of neighborhoods just, a few blocks away. And new small cells were being built out by providers in that community to make sure that there is the connectivity, the capacity, the competition, the access that we need to see. So we got to tackle this issue, rural-urban access, or I say availability and affordability at the same time.
So we've been talking big. Let's go a little small here. What do you, again, back to what do you need for this community? What are the key metrics that you think we should be capturing in order to show the program's success? What are the parts that we need to get dealt with? Because ultimately, everybody on this call is champing at the bit. We need to know what you think success looks like and what should we be collecting to help show that?
Yeah, one of the bigger metrics that we look at, obviously, is cost savings over the status quo. So, for instance, the VA, which has been very active and in a lot of ways leading the way on these telehealth connected cares, they had a pilot where they were able to show that through connected cares, they were seeing something in the order of $1,300 in terms of treatment costs for patients, whereas traditional care models were something in the order of $13,000. So helping us see that significant delta, if it's there, between traditional care models and connected care models is a big, important data point for us. And of course, health outcomes as well, which can be measured in different ways. For instance, if it's diabetes, you can look at A1C levels. You can look at hospital night stays, readmissions. There's a lot of different data factors that can be looked at. But we got to reorient our system more generally. We touched on this a little bit. I was on the road, and I won't call them out by name, but I was meeting with a healthcare provider, and they were talking about just the systemic bias in the healthcare system. They said they can treat the same patient in-house overnight and get, I'm making up numbers here just for ease of reference, $100 a night for treating that patient in-house, and they can get $10 for treating the patient remotely through telehealth. And there are circumstances in which, from the patient's perspective, they're getting the same level of care either way in terms of what the condition is that they need help with. But they say, if you have a $10 option for us or a $100 option, where's that patient going to end up? They're going to end up in the hospital, because that's the incentive structure in the system. So we are continuing to work on that, not us at the FCC, but some really smart people at HHS and CMS, other places.
Well, I should note that on this call are several of us who are part of the group that figures out some of those costs, and the incentive structure has been one of the biggest barriers. Payment parity is sometimes how it's referred to. I sit on the Digital Medicine Payment Advisory Group that goes through the codes for CMS, and the inherent bias is one that I want to be clear is not the fault of the physician. It's often that CMS, we had a meeting with the Centers for Medicare and Medicaid, and the part of CMS that looks at research. We met with CMMI, and they were telling us that to get a study done on some of these things, they expected it to take somewhere between 7 and 10 years. And the time that we had that meeting, I pointed out that the existence of the iPhone, the iPhone had only existed 10 years. And so they're telling me that they're going to take 10 years before they release a study. So there's a lot of folks on this call who are working incredibly hard to nudge, cajole, beg, and urge CMS to do more. And I know private industry is never supposed to say nice things about government agencies, but during this pandemic, they have moved mountains to adjust some of those inherent biases that have been really harming caregivers as much as patients. And so to your example, I would urge you, and I know I have the support of others on this call, that the FCC can play an important role on bringing attention to the successes that you have in this program. we'll work hard to give you the data you need. But that actually gives us up to a couple of questions that we've gotten from reporters right now that I'm looking at that I think get to it, which are, how closely are you monitoring the Wireline Bureau as it oversees the application and award process? And kind of what are the elements that, again, need to be done, and where do you see that going? And how much oversight is happening of that award process?
Yeah, good question. When we adopted the order, pretty quickly after the CARES Act passed, we put in place some high-level guardrails to help guide the Bureau's decision-making. But from the Commission perspective, delegated a lot of that to the Bureau. So I've not been micromanaging the Bureau's process in terms of the selection of applicants they get that are ultimately chosen by the Bureau. So I'm not, weighing in with a thumbs up, thumbs down as each application comes in. I think you'll see from the 3 or 4 batches that have now come out, at least the initial focus has tended to be in areas hard hit by COVID. So you see New York, you see New Orleans, you see some in Michigan. So I think you'll continue to see a pattern that makes a lot of sense as these batches come out. But this is really being run, at the Bureau level with them, churn through the applications and seeing which ones make sense in terms of bang for the buck.
Well, I know that a lot of folks will be working very hard to work with fully qualified health centers to get those applications in. I love the fact that you outlined the fact that this is something where it's not just the digging a hole in the ground to pull the wire, but the whole connectivity chain for both ends, from the patient and the care team. But that actually gives us some things that are going to get kind of interesting. One of the areas that we've seen some concern around has been the fact that the COVID-19 Telehealth Fund program doesn't include for-profit hospitals and health centers and only includes nonprofits. I know there's some statutory reasons. Can you help explain that to the reporters and others on the audience, why that difference exists, and what you think needs to be addressed, or if that's just the way it is?
It's a good question. So, historically, when you look at the programs that we have funded, for instance, through the existing rural healthcare program, we built on a lot of the work that we'd already done in those programs in terms of standing up these. We looked to the statutory definitions of eligible facilities that both Congress had specified and that already existed in our rules. And we didn't break any new ground in terms of those entities that are eligible. And that's why for-profit institutions didn't qualify. There's been a petition for reconsideration filed on that issue. And I don't know whether there'll be any action on that or if there is timing. But I certainly understand the basis for the petition, which is to say, look, whatever reason there is generally for these types of limitations, as to treatment of COVID patients, we all look a whole lot more similar in terms of the challenges we're facing and the needs for funding. So I understand at a high level the argument they're making, and we have to just weigh that against some of the issues we have in terms of statutory authority or whatnot. I haven't fully joined that issue myself to know where ultimately I would come down on that question, but there's some valid points they make weighed against the fact that we have established procedures in place as to who's generally eligible.
So since this is not your normal telecom Com Daily audience, do you want to let everybody understand what that means when you say there's a petition for reconsideration? And is this an opportunity for some in the health sector to file? Is this something where they should be, that if they have a concern about that issue, it's something that they can raise? How do they go about doing that with the FCC? Since the FCC audience understands this like, mother's milk, but we've got 75 participants on here who are on the health side of things. Can you help explain that a little bit?
Sure. So when we reached our, decision about who's eligible, who's not, we made that cut. For-profits were not within that cut. A group representing for-profits filed a petition and asked us to reconsider that, which gives us the legal hold, if we end up going that route, to reconsider that portion of the decision and say, yes, for-profits are in. And so absolutely anybody that has an interest in that issue is free to submit a filing to the FCC, either work with you all or other associations or entities to make their views known on that. Again, I haven't made my mind up on that issue yet, but people should absolutely feel free. It's a live issue, generally speaking, to say, yeah, you should let them in, or no, we think you made the right cut. Nonprofits and other types of non-for-profit institutions, should be sort of either first bite at the apple on this funding or the only bite at the apple. At this point, people are free to express their views on that.
Good. And then structurally, it's one of those things where I just wanted to reassure everybody that the commissioners, as you said, you haven't made a decision about it, but you as commissioners, the commission staff, you look at those input, you take that input seriously, and you make a consideration down the road as to what fits best. It's not necessarily done, but that there is opportunity, and you are open to hearing from all viewpoints on this, correct?
Yes. Yep.
Perfect. But that's something else. You mentioned something super important early, and I don't want to lose track of it. You talked about coordinating with HHS. Can you talk to this audience a little bit more about how you're coordinating? And then again, I know this sounds strange, but what can we do to help? A lot of the folks on this call have regular contact with senior officials and deputy secretaries at HHS. What are the things that we can do, because we live in that intersection? You're kind of the newcomer here. What are the things that we can help you, both from an information perspective and also on a coordination perspective? What would you like to know, and what can we do to help?
Yeah. So obviously the FCC, we're sort of the internet broadband experts. We're not, the healthcare experts. And HHS and their subcomponents are, experts on those areas that we don't have. So we've been working hand in glove with them throughout this proceeding. I get daily updates from HHS on the work that they're doing. We have a person that, liaisons with HHS regularly on, telehealth and related issues. So we have a very, very good relationship right now with a lot of information flow. But of course, any healthcare providers that are interfacing with HHS, it's always good to continue to talk to your particular contact about the FCC, because, we're both big organizations. We are pretty tightly connected at this point, but it's always good to continue to talk up, the different programs and what people are doing, and make sure everyone is aware of the programs. We see the same thing on, the education side. So yeah, E-rate has been a big issue, where we've been trying to be as creative and as aggressive as possible to make sure that students get to stay online. And we've been able to work with with the Department of Education and identify billions of dollars that they were allocated that could potentially be used to address the homework gap, and otherwise be used for funding to help kids. That's another example where, the FCC and the Department of Education working together can accomplish a goal that would be, tough for us to do individually.
And I know the FCC is an independent agency, but many of us on this call have had multiple meetings with Jared Kushner and with staff of OSTP and National Economic Council. Are you finding, as you guys are working on this, that there is good coordination between those agencies? And again, are there things that we could do from a providing data perspective, or for others, that would help you as you guys move forward on this pilot project?
Yeah, I haven't had direct contact that I can recall right now. I'm in a deposition situation, but I can recall right now with with OSTP or NEC on the telehealth stuff. I would imagine that there has been some close coordination as there is on other issues as we coordinate with HHS and education. But yeah, I think the same points apply. Always raising telehealth, always bringing up to people's mind the work that each of these institutions is doing.
I know it's hard for the FCC because you guys are an independent agency, but just so you know, many of us have had meetings, like I said, with agencies, and they are asking the same questions you are. OSTP has stood up a group looking at the artificial intelligence elements. How do we do it? A whole group at National Economic Council is asking questions about how do we make this work from an economics perspective. So as much as the participants on this call can be of service, I think in some ways we can carry water between an independent agency like yours and to other agencies inside the government. So we're glad to hear that you're coordinating with HHS. That's the obvious primary vehicle, and CMS, which lives under there, that's critical. But I think this is a national problem as well as a state-by-state problem, and as much as we can do to help everybody understand, I think it's really critical. When you talked about this, how quickly do you expect the whole fund to get spent? We've talked about wirelines doing it, where the oversight is, what the messages are, a little bit about metrics. How quickly do you want this to go out? And how should we be timing ourselves as some of the folks here are looking to apply, and some folks are in healthcare systems that may already be underway? How quickly do you want this kicked off?
The sooner the better. And I've been very pleased with the pace with which the Bureau has been working. I think within a matter of days of the application window itself opening, they released that first batch of somewhere in the order of 3 million. And we've been hitting a pretty good cadence since then of maybe roughly twice a week, I think, putting out batches of 5 to 6 that are in the similar multi-million-dollar ranges. So I think you could spin out that cadence that we're hitting. That may or may not tell you exactly how long it's going to take to cut through it. There may be a ramping up as we continue our processes. It may stay even, but I think the cadence that we're on has been pretty good. And I'm pleased that the money has been moving out the door as quickly as it has. Certainly much faster by having the Bureau do it under delegated authority than bringing it up to the full commission for a vote each time. Although we will be voting at the commission level on the $100 million ones. So that'll be a different structure. But again, time being slightly less of the essence with that one. Although, COVID's going to be here for a while. So I don't think it's entirely right to suggest that even the 100 million will be irrelevant to COVID. Although, of course, even the emergency COVID one isn't always about treating COVID. It's treating a range of conditions as well.
Concomitant, and comorbidity. Well, that actually brings an interesting question. Are you really looking to the COVID-19 telehealth program to kind of provide some lessons learned? Because as you say, it's weird. The connected care pilot started earlier, but process-wise, it'll kind of it's being leapfrogged by the COVID money. So are there specific lessons that you're hoping to learn from there, or things that you think we should be bringing to the table through that?
Obviously, I think it'll be an end in and of itself in terms of delivering really good results. But I do think, to your point, it will be something we can build on as the application window eventually opens for the other longer term 3-year $100 million. Again, I think it's really the way to sort of conceptualize this is to think about the emergency COVID in a lot of ways. People may have different views. That's fine. There's 5 of us at the commission, and there's lots of people outside the commission that have views on it. But I tend to think of it as a subspecies of connected care. I mean, that the same type of thing, remote patient monitoring, connected care technologies. And again, the reason we were able to move so quickly was effectively it is the record in the policy cuts in the $100 million, but we were just able to add 200 to it because it was appropriated, and it adds some additional eligibility for devices. So they're very, very similar programs that essentially started in the same place.
Yeah, and they'll end, like I said, a little differently. What are the other things that you think you'd like to see the commission take when it comes to the deployment of connected care devices? You actually mentioned the VA. Somebody who's, I think, on this call, the Podometrics guys are providing mats, telemedicine mats that people stand on to look for foot ulcers. I mean, that's something that they've been doing within the confines of the Veterans Administration for quite some time successfully. What are the other things that you think the commission can do to support the deployment of connected care devices, whether it's CPAPs or anything else?
That's an interesting, member, Podometrics, and the work that they're doing is important. I did a video call, I believe, with this Navy vet named James, who had a foot condition, a foot wound, and he was able to treat it. I don't think with this Podometric application, but otherwise treat it through connected care, through remote patient monitoring. So the work that they're doing is certainly needed and is important. And the VA is interesting because when you look at the costs, the poles in the tent for doing connected care, obviously the healthcare itself is a big cost, and the VA has that covered by the fact that it's the VA. The internet connection itself, which is something that we can fund, and then devices. And in some instances, the VA has a lot of authority for purchasing devices themselves, perhaps, the Podometric mat that you're talking about. They don't have a lot of authority, from my understanding, on the internet connectivity piece. That was one where for our longer term program, it sort of fit hand in glove. Our absence of authority on devices, our authority on internet connections can really work with the VA in that case.
And I think that's actually an important point. We see, I'm going to use this term, a disappointing number of connected healthcare devices that are relying on 2G chip technology. Some of it's funding, some of it's making sure they can meet all the patients. When people ask, well, what do you want out of the FCC on connectivity? I say we want it now, and we want more of it, and we want it everywhere. And our minor asks are, we want greater broadband in more places all the time. and I think that gets to one of the key things here is we're talking about broadband. A lot of physiologic monitoring doesn't need a lot of data, but there's a whole panoply, especially with optical imaging, looking at radiographs or anything like that, where that connectivity is absolutely critical. I wanted to touch base back a little bit on your 5G, your march to 5G, on kind of what do you think are the key things that we in our community should be aware of that 5G provides? Because, you know, a heart rate doesn't take much to transmit, but a radiograph or an MRI takes a lot. And then when you start getting interactive, it gets even more significant. Where do you think we benefit from 5G?
Yeah, you know, it reminds me, there was a, micro debate a while back about whether, is 5G that much of an upgrade on 4G?
Yeah.
Are there things that you really, can do on 5G you can't do with 4G? Of course, I think the answer to that is yes. And the most obvious example, I think, is one we talked about earlier in terms of the number of devices that can be supported. There's a limit on 4G networks where you don't have that same type of limit on 5G. And to your point, you can have a lot of remote patient monitoring devices that are sort of trickling out data, low bandwidth, intermittent, maybe you can locally store it, push it when it has a good connection. Yep. But there's other applications that are extremely high bandwidth. So having a 5G network with the flexibility to handle devices on both of those ranges is a new development.
Well, I think that's pretty much the key things. We've talked about your programs, we've talked about the money. Again, I think the key thing that our folks are going to come back to you on, Commissioner Carr, is let us know what kind of data you want us to give you. Let us know how that data best serves the FCC, because in this case, the outcome that we all want, better patient outcomes, better physician engagement, and the right reimbursement for qualified healthcare centers is really critical. So make sure that you're reaching out to the healthcare community. We'll continue to work with you so that if you can say, hey, I'd like to know X, that we can go out and then collect that information on X. We've talked about broadband, we've talked about TV white spaces, we've talked about balloons in the sky, we've talked about satellites, and we've talked about 5G small cell deployment. We've kind of covered a whole range of FCC turf. And I want to just say again, thank you for your work in really pushing forward the Connected Care program and your behind the scenes work on the COVID elements as well. Are there any other messages that you want us to carry forth? What's your marching orders to us as a community going forward? And with that, we'll let you go back to your kids.
Yeah, no, thank you. Obviously, continue to apply, continue to submit applications. Tell us what your costs are that we can sort of potentially reimburse. And then to your point, continue to track positive metrics. And we'll take, as much data, good, bad, indifferent, in terms of the outcome as possible. We'll crunch that together and hopefully be able to do something ultimately with the data. I'm thinking most directly, obviously, about the 100 million, because we have the time, we have the 3 years, right, longer term, as opposed to the COVID, which is really about, making an impact now and not distracting people with unnecessary paperwork. But of course, any data that we get and collect from that will be very, very useful as well. And of course, just a shout out obviously to the FCC staff. They've been doing incredible work. The amount of activity they launched into as it was clear where this country was going with the pandemic is really unprecedented. They're doing it in tough circumstances. They either have kids that are home and full-time job at the FCC, full-time educating your kids, not an easy task. They could be taking care of their own parents or other people with health conditions. So really appreciate and hats off to the work that the FCC staff's been doing.
All right, and at that, we'll get to work. Hopefully we'll get you the data that you need, and we'll let you get back to work to pushing forward on telemedicine. Alex McLeod, is there anything more that we need to do, or can we let the commissioner go?
No, I think it's been great. Thank you, Commissioner Carr. As a former FCC intern, it's good to see that you guys are making such good progress. So
exactly. Thanks. Great. Really appreciate it.
Thanks, Commissioner. Have a good day.
Thanks, everybody.